People don't go into using alcohol, pills and other drugs to say, I want to ruin my life. They go in there because they're thinking, life's not working for me, I need a hand. They should really say that they're after in their life what we're after: happiness, fulfillment, well-being, a sense of purpose and direction. So I guess what we'd be after in working with our people is to restore that sense of direction and hope and purpose with less risk-taking, health risk-taking behaviours. My name is Rod. I help people who live with drug and alcohol and mental health problems. This is my experience. I've worked here at the Lyndon Community since it began here on this site. One of the issues that I think we have with a lot of people with drug and alcohol and mental health problems is they actually don't present. We know both from clinical experience and from the National Survey of Mental Health and Wellbeing that people with 2 or 3 comorbid problems now more likely to present. So here they are presenting, and then we say, well, hang on, you're only allowed to have this problem in our unit, not that one, or you're only allowed to have this one in our unit and not that one. And then we talk about not being able to engage people in treatment. It seems to me, if people present with a whole load of issues, we have a better chance of engaging with them and saying, what is the concerns you most at the moment? Where would you like to start dealing with this? I mean, I know there are issues about people for compulsory treatment and so forth, and that's a sort of a separate issue. But I think in the long run, even if people have had involuntary treatment, the issue is still how do we engage them in a continuing relationship towards improving their health care and their well-being. And surely that's addressing the issues that they come with rather than the issues you tell them they've got. The approach of meeting people where they are with the issues they have is one that enhances engagement, and long term that will be beneficial. But even with people with psychotic illness, there will be periods when they understand a good deal more than we perhaps give them credit for. Long term, they're probably going to be free range. They're going to be out in the community doing their own thing. If we don't understand what it is that motivates them, that worries them, that they want to address and so forth, they're going to be cycling in and out of involuntary treatment because they're not following our treatment plan. Why do they not follow a treatment plan? Because they don't understand it, they're not part of it, it doesn't respect their dignity and their human rights. And if from time to time they use chemicals we don't approve of, that has nothing to do with it. We still need to try and understand that in terms of their own experience rather than what we think is right or wrong. I mean, an example of a happy result was a woman who'd had a long history of polysubstance use, including alcohol, but more recently had got into Xanax, which is quite a popular drug of misuse. And as a result of that, her life had pretty well fallen apart, and she'd locked herself into a house, lost her licence, all these kind of things. She was detoxed here. She was adamant that she was not going to take anything else, but when she got home to an outlying town, had return of her symptoms of anxiety and agoraphobia. We then liaised with the mental health nurse there, who was fairly new but kept in touch with us. And as a result of doing some home brief interventions at home over a period of time, she's now been 6 months off everything, got a licence back, visiting a daughter on the coast in the car, and of course, needless to say, not using benzodiazepines or alcohol. We can't say it's permanent, but it's certainly a good deal better than it was a year ago. The bottom line still is, here's a real person who's in distress. What are you going to do? Are you going to fob them off? Are you going to bounce them between services? Are you going to say they belong to someone else? Are you going to say, let's engage with this person? And we don't know really what's going on. But in mainstream healthcare, if I come in with a bellyache, they don't say to me, oh gee, we don't know if it's your gallbladder or your liver or your appendix or this, so sorry, we don't know what it is, so you'll have to go away. They say, you've got a bellyache, you're not well, You need care, you need a diagnosis, you need a treatment plan. Even if you can't make a diagnosis for a day, for 2, for 3, for 4 days. If I'm crook and in distress, I stay in the hospital till they sort me out. What's the problem with mental health and drug and alcohol facilities adopting that same approach? When a person is crook and they need care, our duty of care is to look after them.